Thank you. Now we're going to switch gears a little bit. We're going to look at bladder cancer. Bladder cancer is one of those diseases in which the lack of surgical aggressiveness has a lot to do with the natural evolution of the disease and the patient's survival. Contrary to prostate cancer, even kidney cancer and a few other neoplasias, bladder cancers does not admit many mistakes as an implacable disease. There are several scenarios. Patients with bony metastasis, and these are patients that are not candidates for radical initial therapy, and systemic therapy usually is the best therapy. Problems come when we have patients with aggressive, invasive disease without any kind of metastasis. In this case, we have several paths to follow. Patients with that have a regular or normal PET or CAT scan, we operate on these patients. Apparently, their nodes are normal, and we send them to the pathologist, and the pathologist says nodes or normal. Great. Everything seems to be okay. Nevertheless, there's a group of patients that in this scenario in which the pathologist says that everything's okay, and after a few months, the patient develops a pelvic node disease. There's another group of patients in which, before surgery, we find no evidence that the nodes are involved, so we perform our lymphodectomy. We send it to the pathologist, and the pathologist says that indeed there was a node metastasis. And there's another scenario, another group of patients where before the surgery, due to iconography studies that they have node metastases, we know that if they have at least 5 node metastases, they will be considered patients with oligometastatic disease. However, what is the impact of managing these nodes during surgery? There is something important in a lymphadenectomy of these patients, and as we will see, there is. For example, the first point is the number of nodes. Most people and most surgeons that do radical cystectomy, they do it regionally and dissect the obturator nodes, whether internal or external. And when you analyze the impact of this number of nodes that are resected during surgery, and we look at the 10-year mortality of these surgeries, there is a clear difference when patients have less than 10 nodes involved, or when there are more than 10 nodes involved. When we resect more than 10 nodes in the lymphadenectomy, the recurrence of disease is 10% higher than in those patients in which we are resecting less than 10 nodes. There are a few interesting trials. For example, in this group of patients where we had more than 500 radical cystectomies with no information of metastases before surgery, and then they discovered that they had positive nodes. The pathologist reported these nodes as positive. Nevertheless, patients did not receive adjuvant treatment. When the impact of the number of nodes on the survival of these patients was analyzed, those that underwent a lymphadenectomy had less than 20 lymph nodes resected, and they had 5 to 10 years survival, and their disease-free survival rate was completely different to those of patients that had more than 20 nodes involved. And so in patients with positive nodes, lymphadenectomy, the larger the number of nodes that you resect in this surgery will have a true impact on the patient's survival. So what happens in patients that undergo lymphadenectomy and have a pelvic local recurrence? The number of nodes also has an impact here. When patients have less than or more than 11 lymph nodes that are resected during the lymphadenectomy, and there is a positive report, the potential of having local recurrence is much lower than when they have less than 11 nodes. And evidently, when the nodes are negative, the larger the number of nodes that are collected during the lymphadenectomy, the risk of local recurrence is much greater than when we remove a smaller number of nodes. So the kind of lymphadenectomy will have an impact on patient survival. When we compare patients that do not undergo lymphadenectomy versus those that undergo conventional lymphadenectomy and versus those that undergo extended or super extended lymphadenectomy, there's a clear difference in the disease-free survival and in the overall survival of patients. One might say, well, what does this mean? Well, that in bladders, lymphadenectomies will afford the possibility of a cure. It's difficult to say, but there is evidence that the greater the number of nodes that are removed, the greater the potential or the possibility of the patient surviving. So what explains this? Well, this is a very interesting trial done in Japan on patients that underwent extended lymphadenectomy and radical cystectomy. And the patients were first checked by a group of pathologists, and then they were checked by another group of pathologists. In patients in which the pathologists reported no metastases, they underwent a pancytokeratin trial, and they found that 8.2% of the patients that originally had been reported as having negative nodes, 8.5 of them have micrometastasis. And when they compared the survival of these patients without any adjuvant treatment, where no metastasis was reported, versus those that did show micrometastases, they were compared with patients from which from the beginning they were metastatic. There's a clear difference in this case in survival. Patients who have micrometastasis practically experience the same thing that those patients that have no metastasis, provided a large number of nodes is removed. And this is a full comparison. So, this explains why patients that theoretically show a negative CAT scan, and the pathologists tell us that they have negative nodes, it turns out that they're micrometastases and the pathologist cannot detect. And that explains why patients will have tumor progression and why patients will have metastases later. And this explains why, if we remove nodes from these patients, this is the only opportunity that we have to remove a node that does not yet develop a metastasis and might have an impact on the evolution of the patient. And this is the kind of node that will be benefit by using neoadjuvant chemotherapy before radical cystectomy in high-risk patients. Currently, there's a large number of trials looking at neoadjuvant chemotherapy that have proven that indeed there is an impact on certain patients when they apply at least 3 cycles, especially when they are platinum-based. And when meta-analysis when comparative randomized studies have been compared, there's an impact in favor of patients with aggressive tumors that receive 3 cycles of chemotherapy before radical cystectomy, provided platinum is used. So what we're tackling is the second scenario, nodes with a small metastasis that anyway will go undetected by the pathologist. There's no question that using modern iconography with fluoroxyglucose PET scans allow us to see things that we didn't see before. For example, bony metastasis in a conventional study would have gone unnoticed, or small nodes that if we didn't see their metabolic activity, we would have considered them completely negative. So these advancements have been very useful in the pre-op evaluation of our patients. However, when we analyze using PET scans together with CAT scans, we see the sensitivity of these tests, both PET and tomography, even a combination of PET and CAT scan, the sensitivity is actually very low. Predictive value of a positive test is also quite low. So all that is high is the specificity and the predictive value of a negative test. Nevertheless, in every test, we see the same thing. This iconography is useful and good, but is in no way infallible, and we cannot make decisions of not providing neoadjuvant treatments in patients who have negative CAT scans or negative PET scans. So the question is still, it remains in the air. So how can we decide which patients we can provide neoadjuvant chemotherapy to and not put them at risk for toxicity, because these treatments are not innocuous? Maybe the answer lies in the histopathological specimen of the transurethral sample before surgery. The best predictor is the aggressiveness of the tumor. The presence of a high-grade neoplasia will determine whether the patient can develop micrometastasis or have oligometastasis. The involvement of the muscle layer has a lot to do with all of this. In fact, 50% of patients with muscle involvement, 50% of these patients have metastatic disease. Another important finding that is often overlooked and which is actually very useful is when we do meta-analysis of the outcomes of the finding of hypovascular findings, when we assess the recurrence-free survival and overall survival and cancer-specific survival, lymphovascular disease has a lot to do with this. Patients with aggressive disease and lymphovascular invasion have up to 63% possibilities of having an oligometastatic disease. And this is one of the basic considerations to help our patients with neoadjuvant chemotherapy. Currently, the use of all genetic weapons that are arising these days allow us to conduct certain promising tests, and maybe in 2 or 3 years the results will allow us to indicate what patients will benefit from chemo, and secondly, who will actually have a better response with the use of platinum and who will develop resistance to platinum, especially patients that cannot be candidates to using chemo due to certain particular mutations. This is still in the experimental phase. It's promising. I trust that in the next few years we will receive news about this. Nevertheless, many of these trials are conducted in specimens after radical cystectomy to try to identify who will benefit from adjuvant therapy and not necessarily only neoadjuvant. This is the only trial using the tissue from the transurethral resection to determine the predictive value of the globular status of patients before and after cystectomy, and this plots out 20 genes and can somehow determine the predictive value of a predictive test in up to 70% of patients who might have oligostatic disease and therefore be candidates for adjuvant or neoadjuvant therapy. There is a large number of tests that are analyzing different kinds of drugs, not only platinum, in order to decrease the toxicity of these treatments, and this will soon allow us to have nomograms and better predictive indicators to determine which patients will benefit from running the risk of toxicity. This is today the only nomogram of patients before radical cystectomy. On the other 18 nomograms that we have at this time are on patients after cystectomy. And this is something that has been validated, is quite useful, and I think that this is something that we need to use before radical cystectomy. In conclusion, oligometastatic disease might be the fine-tuning that will allow us to determine the treatment of a patient or the management of a patient with a bladder invasion, and very likely node management is of huge importance. We need to perform increasingly extensive lymphadenectomies. Limited lymphadenectomies and small interventions with a small number of nodes is completely useless and makes it difficult to manage our patients afterwards. So, up to this point, patients who have an aggressive disease or a lymphovascular disease with aggressive histopathological evidence will benefit with two things, with adjuvant chemo and extensive lymphatic resection, a very extensive lymphadenectomy in these patients, and that might be the best mode of treatment that we have today. Thank you.